A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to this 23rd Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis among children. On behalf of the National Institute of Tuberculosis and Respiratory Diseases, I extend a very warm welcome to the directors and representatives from NIRT, NTI, state TB officers, directors of STDCs, esteemed faculty members from medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in today's session. Dr. Shobhini, Deputy Director General TB Central TB Division, is busy in another meeting. She may be joining the session later in some time. So now let me please introduce the faculty from NITRD. I am Dr. Dulika Dhingra, Specialist Pediatrics at NITRD, and I will be moderating today's session. And with me is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB and also former Director of NITRD. To my extreme right is Dr. Alok Yadav, CMO NFSG and pediatrician at NITRD. I would now request Dr. Sangeeta Sharma to please address the gathering and welcome the audience. Over to you.
Thank you, Dr. Dhulika. So we are gathered again on a Tuesday afternoon. As you're all aware, that this Paediatric TB Eco platform is an effort to disseminate knowledge, and it's a platform with active discussions where we learn from each other. And based on the feedback, we have reverted back to comparatively simple cases so that all who are bored join us, they gain. That was the feedback which we received, because we were told that some of the cases are a bit too complicated and they're not seen so commonly in clinical practice. So today's case is a very common scenario which we have all faced in our clinical management of pediatric TB cases. And so without wasting time, now I'll hand over to Dr. Dhulika and to carry on further.
Thank you, ma'am. Without any, before we begin the session, I would request everyone to please take up the pre-test questions, the link for which has been shared on the chat box. So now for this session, today's session, the presenting team is Department of Pediatrics, Postgraduate Institute of Medical Education and Research, Chandigarh. And the team is led by Dr. Joseph L. Matthew, head of the Department of Pediatrics at PGIMER, Chandigarh. The case will be presented by Dr. Charu Singh, senior resident in the same department. Over to you, Dr. Charu.
Good afternoon, everyone.
Yes, Dr. Charu, your screen is visible. You can start.
So I am presenting the case of Master S, who's a 13-year-old male child who was admitted to us in November 25.
Bit loud.
Good afternoon to everyone. I am presenting the case of Master S. He's a 13-year-old child who presented to us in November 25 with the chief complaints of fever for 3 months, cough for 3 months, and breathlessness for about a month. In the history of present illness, the fever were noted to be of 101 to 102 degree Fahrenheit. It was an evening rise, relieved with oral medication. The cough was productive. Yellowish, thick sputum was being produced, which was more during early morning hours, associated with post-acid vomiting. Breathlessness was exertional, which progressed from initially on climbing one flight of stairs to even on walking for 200 meters, though it was not associated with any postural variation. Apart from that, there was history of significant weight loss of about 7 kg over past 3 months, that is from 38 kilograms to 31 kilograms, and it was also associated with loss of appetite. With the above complaints, there was history of admission at outside hospital where the patient was admitted twice in the last 2 months, have received oral antibiotic at each admission with only partial relief in the symptoms, and was then advised for certain radio imaging, and the patient was then referred to our setup. There was no history of associated chest pain. There was no history of hemopsis, any TB contact, abdominal pain or vomiting or altered bowel habits, neck swelling, or altered sensorium seizures, blood, or double vision. On examination, patient had a weight of 30.7 kg with a Z score of minus 1.48, and the height was at minus 1.42 Z score. The BMI was minus 1.18 Z score. The journal physical examination did not show any pallor, lymphadenopathy, or other abnormalities. Systemic examination, in the respiratory system examination, on inspection, the chest was symmetrical with trachea being midline. The chest wall movements were equal on both sides. There was no chest wall deformity or scars, and the apical impulse was seen in the fifth intercostal space, which was just medial to the mid-clavicular line. On palpation, the findings of inspection were confirmed where the trachea was in midline, apex beat was in the fifth intercostal space, chest expansion was equal bilaterally, and the tactile vocal fremitus was normal in all areas. Percussion, it was resonant in all areas, and on auscultation, normal vesicular breath sounds were heard bilaterally. In the per abdomen examination, it was soft, non-distended, no organomegaly was detected. In central nervous system, patient was oriented to time, place, and person, and no other focal neurological deficits could be seen. In the cardiovascular, no other abnormality was detected. Based on the above clinical picture, the impression made was of presumptive pulmonary tuberculosis. Considering the clinical impression, we then moved forward with the investigations, and on a complete blood count, a hemoglobin of 10.2 was found, with a total leukocyte count of 10,000, which was with polymorphic predominance of 74%, and the platelet count was of 4.6 lakh. The chest X-ray of the patient, as shown, revealed inhomogeneous infiltrates, which were not suggestive of, which were not specific to TB, though there were chest abnormalities. In the tuberculosis workup, sputum AFB smear was negative. The MJIT smear was negative. The MJIT culture showed no growth after 42 days, and the CB-NAT was not detected. Because there was scanty sputum being produced, and thereby GL samples were also planned in order to increase the yield of the samples. As we can see, none of the samples revealed evidence of AFB, that is the acid-fast bacilli. Following the three gastric lavage samples, which were negative, we had done a bronchoscopy which showed right bronchus intermedius lumen, which was obstructed due to compression of some outside non-pulsatile structure, likely to be a lymph node. BAL revealed, the BAL cytology revealed a cell count of 1,261 with a with a neutrophilic predominance of 55%, and the monocytes were 45%. Rest entire workup came out to be negative. And this is the bronchoscopy image, which is showing the right main bronchus. As we enter the right main bronchus, we could see the opening of the right upper lobe, but the bronchus intermedius is completely obstructed. The CCT chest was thereby done, and you can see that the mediastinal window shows enlarged lymph nodes. It seems to be like a mass if you could follow the cursor that I am showing you. The lung window showed left-sided upper lobe nodule along with a mass on the right side. The CECT chest report, which was done outside, was suggestive of subcarinal, visceral, mediastinal soft tissue mass that showed heterogeneous enhancement with encasement of bronchial intermedius and close abutment of the adjacent bronchi, great vessels, and esophagus, with small calcified nodule in the left lower lobe, likely heel granuloma with mild right upper lobe band-like opacities. Following which, in order to attain a microbiological diagnosis, we had further gone for endoscopic bronchial ultrasonography with transbronchial needle aspiration, where again cytology was negative for a ZN stain and there were no malignant cells. The MGIT culture showed no growth after about 42 days, and CBNAT did not detect Mycobacterium tuberculosis. The USG abdomen was also done, which showed no ascites. The liver and spleen were normal in the size and the echo texture. There was no evidence of significant retroperitoneal or periportal lymphadenopathy. There was no thickening of ileocecal junction, and ophthalmological evaluation did not show any choroid tubercle or flectins. So the cause of illness so far, as on the follow-up visit, which was done on 19th of December, was that we did not have any microbiological evidence. Patient was diagnosed as intrathoracic tuberculosis, that is pulmonary and mediastinal lymph node. ATT was thereby started. Patient was started on the fixed drug combination, which is H was started at about 8 milligram per kg per day. Rifampicin was 14.5 milligram per kg per day. Z was 35 milligram per kg per day, and ethambutol was 24. Later, on 31st of December, patient presented to OPD with the complaint of nausea for about 5 days, vomiting for 3 days, and decreased appetite for 3 days. When possibility of drug-induced liver injury was considered, and the LFT was as below, that is the AST of 722, ALT was 452, the T-bill was though not elevated. The liver, the viral markers were non-reactive, and thereby HR and Z was stopped. At this point, patient was started on hepatoprotective regime, which is amikacin, levofloxacin, along with ethambutol. On 3rd of January 26, there was clinical improvement in the symptoms after the initiation of hepatoprotective regime. There was no episode of vomiting and the appetite had improved. The LFTs were in the improving trend with an AST of 85 and ALT showing a falling trend. The ALE was thereby continued. So over here, you could see how the AST and the ALT, what were the trends like. So 31st of December was the day 12 of ATT, when he was first diagnosed with drug-induced liver injury, where HRZ was stopped and ALE was started. On 3rd of January, there was a serial, after every 3 to 7 days, serial LFTs were done, where ALE was continued. And on about 22nd day of modified, on the 22nd day of ATT, that is on 10th of January, first isoniazid was started at 50% of the dose, following which 3 days later, as the liver enzymes were showing a falling trend, the H was introduced at 100% of the dose. Though on 17th of January, you could see that there is a relative rise after the isoniazid was introduced, and thereby ALE was continued while H was then stopped, following which the liver enzymes were gradually followed, and at follow-up visit, the rifampicin was then added at 50% dose, and on February 4th of February, the rifampicin was introduced in 100%, that is at full dose. On 11th of February, the regime was, we were on amikacin, levofloxacin, ethambutol with 100% of rifampicin, and now even H was introduced at 50% of the dose. On 18th of February, the isoniazid was made at full dose, and now on 25th of February, as the AST and the ALT levels were within the normal range, it was about 68th day of ATT. So my question is that what is the plan now? Like what is the plan now? What is the next drug to be added over here was the question. So in summary, we have a clinically diagnosed intrathoracic tuberculosis, pulmonary and mediastinal, which was started on ATT on 19th of December. Patient received HRZD for 13 days. Was started on modified ATT on 31st of December in view of drug-induced liver injury and was on modified ATT, which was received for about a month and 25 days. So how do we restart ATT? So this is a table which shows you how sequentially we have had guidelines from British Thoracic Society, from American Thoracic Society, WHO, the Asia Pacific Study of Liver, Association of Study of Liver, and now we have the NTEP guidelines where they say that we reintroduce ATT when the ALT is less than twice the upper limit of normal. And as per NTEP, it is again the same when the ALT is less than 2 times the upper limit of normal. Where the order of reintroduction, you could see that as per the old guidelines of British Thoracic Society, they had advised for first adding isoniazid followed by rifampicin followed by pyrazinamide versus in NTP, as you could see, that we have R to be introduced at full dose. After 3 to 7 days, isoniazid is added, followed by full dose of pyrazinamide. And the LFT, the monitoring of the LFT is varying from 3 to 7 days after the isoniazid has been introduced in the patient. Now, the question arises as to what is DILI. So where did this term come from? This is a table that shows you how the terminologies have evolved. There are various studies where the use of the term drug-induced liver injury, then you have another study from 2019, which has used the term anti-tuberculosis liver injury. And in 2019, there was a study which used the terminology anti-tuberculosis drug-induced hepatitis. So all in all, we have a entity where the liver enzymes are elevated that is complicated by the anti-tuberculosis therapy. So over here, various terminologies including hepatitis, hepatotoxicity, liver injury, hepatic dysfunction all have been used. And if you see from 2012, where first the terminology came as hepatic dysfunction, followed by in 2013, where the study used the terminology anti-tubercular drug-induced hepatotoxicity, and gradually over the course to the recent study in 2022, which uses the term tuberculosis drug-induced liver injury. And as per the definition, the AST and the ALT should be 3 times the upper limit of normal with symptoms. ALT and AST should be more than 5 times the upper limit of normal without symptoms, and bilirubin to be more than 1.5 milligram per deciliter. So one might ask that if there are no symptoms, why the ALT and the AST are to be done in the first place? So the answer to it is that it is a severe adverse event or liver injury liver injury caused by the anti-tubercular therapy is a severe adverse event. Thereby, we monitor these patients with LFT. And as you could see on the very right of this table, that a monitoring table is also given that how do you monitor these patients with the LFT. So you monitor them at baseline followed by 2, 4, and 6 week, and then every 2 months. So that is how you come across patients where the ALT and the AST must be elevated about more than 5 times the upper limit of normal without any symptoms. And there are various definitions given where you could see the one in 2022 shows a bilirubin of more than 1, whereas that in 2019 used a cutoff of 2 milligram per deciliter. And similarly, in 2019, there was also a definition which stated more than 1.5 times the upper limit of normal if the baseline is abnormal itself. Before we proceed further, I would like to give you a small scenario that if a patient is asymptomatic and let's say that the AST and the ALT is just 3 to 4 times elevated, so it does not meet the definition of drug-induced liver injury. So how do you label this particular clinical condition, and should we switch to modified ATT? So the answer to it is that you call this particular clinical condition as hepatic adaptation. It is a transient asymptomatic elevation of the serum transaminases during the early phase of ATT, and it resolves spontaneously with the ongoing drug therapy at the same dosage without clinical symptoms or intervention. Now, if you misinterpret the hepatic adaptation as anti-tuberculosis drug-induced hepatotoxicity, it can lead to premature discontinuation of ATT and thereby may lead to patients with treatment failure, may cause relapse of tuberculosis. There can be development of drug resistance and increased morbidity and mortality, particularly in the pediatric population. Recognizing hepatic adaptation thereby ensures uninterrupted tuberculosis treatment, a better disease control, and reduced risk of ATDIH related complications. So I would like you to have a little, there is a word that is first time used over here, that there is this uninterrupted tuberculosis treatment. So do we say that when we give a patient modified ATT that we are interrupting the tuberculosis therapy? That is the next question. So how to proceed further in the given case? So one would say that we will omit the levofloxacin and amikacin, and we will continue the patient on HRE as 2 months have completed. So we will continue with the continuation phase of this patient. But that is not the case. So then what is the case then? So as per the Childhood Tuberculosis 2021 guidelines, in case of forced interruption due to delay, the interruption when in the first 4 weeks, we need to restart the therapy. So what is this interruption? So interruption of ATT when? So as per the Childhood Tuberculosis 2021 guidelines, two terms have been used. One is forced interruption, the other is an unplanned interruption. Despite the patient being on hepatoprotective regime, and one might think that we are continuing with the ATT drugs, we must understand that this is not the original tuberculosis regime that is advised for the patient. These forced interruptions are usually due to drug-induced liver injury or other severe adverse events, including QTC prolongation, optic neuritis, and hearing loss. Whereas unplanned interruptions are mainly due to non-adherence of the ATT. As per the CHTB 2021 guidelines, forced interruption when due to delay, we need to restart the therapy when feasible. And as in our case, the interruption was within the first 4 weeks, we'll have to restart the regime with this particular patient. Then comes, how do we manage the treatment interruptions for those with non-adherence? So again, you could see that if the interruption is up to 4 weeks, we would resume the therapy. Though if it is beyond 4 weeks, we will have to reinvestigate for drug-resistant tuberculosis in such patients. Now, how do we decide about the total duration of ATT? So recommended duration of ATT for intrathoracic tuberculosis is about 6 months. The total duration will be adjusted for the number of days the original treatment was missed, and the days of modified ATT regime will not be counted over here. So does modified ATT also warrants for reinvestigating of the drug-resistant tuberculosis? So guidelines do not talk about this, and we need to follow up the patient. So in our case, clinically, there are no complaints of fever or fast breathing, though there is persistence of intermittent episodes of dry cough. The appetite has improved. The current weight of the patient is 32.1 kg. Patient is compliant to therapy. The drug-induced liver injury has resolved. There is reinitiation of isoniazid, rifampicin, pyrazinamide, and ethambutol from 4th of April 26. So we have restarted the patient on intensive phase. Currently, the patient is on isoniazid at 9 milligram per kg per day, rifampicin at 14, Z at 30, E at 25. And the recent LFTs, which are dated 28th of April, are the T-bill is 0.71 and the AST and ALT are 33 and 30. Thank you.
Thank you, Dr. Charu. Are there any questions from the audience with regard to the case? If there are any questions, we can clarify them right now before we go on to the discussion.
ये ना present को ये वाला present.
Any questions from the audience?
Yeah, good evening, madam. My question is, madam, AMIC acid, how long can we continue, madam? For 2 months?
You know, saying that we need to show you what is the actual standard protocol, because there, I feel, with due respect to the presenter, there have been some, I would say, areas where management should have been done as per the protocol. So the protocol has been defined, and all this is available under the ICMR standard treatment workflows. And the thing is that the criteria they remain the same, that with symptoms or without symptoms. If there are no symptoms, then the enzymes more than 5 times, and with symptoms more than 3 times. Bilirubin 1.5 milligram there is the cutoff. Now you stop the Z. That is also appropriate. उसको share करो. ठीक है. Now next comes you start the alternative. So this is yes. देना इसको. So these are the risk factors. You all know risk factors of underlying risk factors would be different. Are there any questions you have to discuss this?
I have one question. Can you clarify that at the end in the on the 25th of February when the AST and ALT enzymes are within the normal limit, then is the pyrazinamide was added in this patient? Any trial was given the pyrazinamide or not? Because in the last, on the 18th, amikacin, levofloxacin, ethambutol R and full dose of H is added. Any pyrazinamide was added in this patient?
Sir, yes, sir. Our last slide does mention we have started the patient on H, R, Z, and E now. And the Z was introduced on 4th of April. And I have also showed in my slide the follow-up LFTs, which are dated 20th of April, which are in the normal range, sir.
No, but your LFT was essentially normal. Initially, there was no need of stopping INH. Once you had started INH, and I don't remember the exact the levels, but then
49 and 50.
When they really stopped, then H was stopped on 17th of January. There was no need to stop the H. Although NTP has recommended that we start with rifampicin, but then there is, you can also start with INS, that's personal choice, but you have to start with full dose. That is what is the WHO recommendation, NTP recommendation. I'm not going into the, the individual studies. But what are the recommendations? They are based on all the data which is gathered and analyzed. So the recommendation is that if your liver enzymes they remain less than twice the normal, you can start either rifampicin or INH. So in your case, you started INH, that is okay. But again, on 17th, the level remains below twice, and you stop INH. Then you started rifampicin. I mean, this is not the kind of protocol which is to be followed. The protocol which needs to be followed is that you start rifampicin or INH. Most clinicians and NTP and WHO says start with rifampicin. And if the levels remain less than twice the normal, then you have to get the repeat levels done every third and seventh day. If the levels remain the same, then you reintroduce the next drug. That is INH if you started with rifampicin. Again, with the full dose. And again, repeat the LFT after 3 to 7 days, depending upon if the third is still a bit raised and on the seventh day. And you introduce the third drug, that is the pyrazinamide. So you don't have to take so long in reintroductions because the try is that we need to reintroduce the drugs at a comparatively faster rate, keeping in mind the LFT levels. The basic is that the LFT, if it is less than twice, that is almost less than 100, please reintroduce the next drug. And once you have reintroduced rifampicin, INH, and pyrazinamide, and the LFT remains less than twice the normal, then you this time period of the alternative regimen, that is ALE, amikacin, levoflox, and ethambutol, has not to be counted. Now your clock starts from the time the reintroduction has been complete. Now the other thing which you highlighted was that you need to get a routine LFT done at second week, fourth week, sixth week. You showed an article. This is not the practice which is recommended under NTP or by the WHO. You don't need to do the LFT so frequently. Only if the patient has symptoms, symptoms and the most specific symptom is because these drugs they can also cause gastritis. So vomiting, etc. is common, but anorexia is more specific to the liver induced injury. So if a child is having anorexia, it's more likely that there is any liver associated DILI, what we call as. So this is the standard treatment workflow which has been finalized and it is available in the ICMR standard treatment workflows.
Sangeeta,
So, yes, sir.
my basic question is what prompted them to start ATT? So first, what was the rationale? It was clinically diagnosed or what was the rationale of starting ATT, diagnosing tuberculosis?
Okay. Okay. So starting ATT, that is the question.
Sir, the rationale was the clinical picture where the patient was having a significant weight loss along with fever, productive cough, which led us to make a differential of presumptive pulmonary tuberculosis, based on which we had attempted certain investigation where the CT findings were suggestive of mediastinal lymphadenopathy, and the bronchoscopy also showed that there was near obliteration of the right bronchus intermedius from a non-pulsatile outside structure likely to be lymph node. And despite intensive workup, which also included endobronchial ultrasound with transbronchial needle aspiration, we could not make a microbiological diagnosis. So
Did you,
Thank you.
did you
yes.
give a course of antibiotics? Because according to the NTP standard treatment algorithm, the diagnostic algorithm is if there are chest X-ray findings which are not highly suggestive of tuberculosis, that means that there is no fibrocavitary disease, miliary tuberculosis.
Ma'am, the patient had already been admitted in the past twice at the outside hospital and had received oral antibiotic of variable durations, despite which the fever spikes, the cough production, and the clinical picture showed no improvement, and thereby he was suspected to have we had made the clinical impression of a presumptive pulmonary tuberculosis, and the investigations then followed, and that is how we made the final diagnosis of clinically probable pulmonary and mediastinal intrathoracic tuberculosis.
Mhm.
And regarding that, the doubt that we are having, we only do LFTs when the patient is symptomatic, which my professors have also raised an issue. Why do the guidelines talk about that when the patient is asymptomatic, the AST and ALT are to be increased to 5 times the upper limit of normal? we have already had this discussion over here, but why do the guidelines talk about it? Then how did we pick it up, the AST and ALT, if the patient was asymptomatic?
Is getting routine LFTs. But if it is done for some other reason, like if there is any underlying known hepatic disease as other risk factors, there are risk factors for ATT hepatitis. As are visible on the screen, that is history of underlying liver disease, if you have history of jaundice, ascites, GI bleeding. Are there any physical findings of liver disease, splenomegaly, ascites, icterus, or the child? I mean, in children, alcoholism is not there, but still, I mean, I've had cases where children are drug addicts. So, still there is, especially in orphans or the roadside street children. And there is hypoalbuminemia, there is now, normally, if there is elevated amino in these enzymes at the baseline, if you encounter a report, you will obviously get a repeat done. But normally, you do not. If there is any risk factor or there is pre-existing liver disease, then even if the child is asymptomatic, then you need to, get uh, the enzymes done. So, am I clear on this or not?
Yes, ma'am.
Am I clear with my answer? If there is any risk factor or there is any pre-existing liver disease, even if the child is asymptomatic, then you get the liver enzymes done.
Okay, ma'am. But ma'am, in each case, that will not be the matlab, patient may or may not have risk factors. And the guidelines usually talk about it that it is more than 5 times the upper limit of normal when asymptomatic. So there is no prerequisition always talked about that each time there is a
So,
patient.
because with ATT, in fact, that is a drug test. That ATT should cause some enzyme elevation. That shows the authenticity of what you are giving is true ATT. So you expect some elevation with these drugs. All of these drugs, they are hepatotoxic. अगर आपका पेशेंट एटीपी ले रहा है और उसकी लिवर एंजाइम्स बिल्कुल नॉर्मल है तो हैव अ प्लीज थॉट कि whether these drugs are true ATT or not. I've had children given, because some parents they prefer to take ATT from the private, the chemist. So, and there was no elevation of liver enzyme because the child had pre-existing liver disease. The LFT remained normal. So when we got that, I told the mother, please get the what you're giving. So she got them, and to our utter surprise, we got it tested, and it was not ATT. So some rise in liver enzymes is expected when your child is on ATT or a patient is on ATT. Rise तो नहीं है. But that does not mean that we start to stop ATT. That is the reason the guidelines they are very clear that if there are symptoms, then 3 times. If there are no symptoms, then 5 times. क्योंकि कोई किसी को पहले कोई लिवर डिजीज है उसकी एंजाइम्स बढ़ सकती हैं और अगर वो एसिम्टोमेटिक है तो 5 times हम जा सकते हैं.
Okay, ma'am. In our case, we had symptoms.
Yeah, you had symptoms, and the more specific symptom which I've seen is anorexia. Because these drugs they cause gastritis, so there could be vomiting, abdominal pain, flatulence due to other drugs. But if your child is having anorexia, you will see that it is almost always associated with DILI. So this is the algorithm. We just go run it through. So once there are no risk factors, then the diagnosis of ATT hepatitis is made, and you stop all the hepatotoxic drugs. Uh, I've already, talked about this. You can just go through, or Dulika, you just read this out, fast. Because I've already, explained.
We screen the children for risk factors, which we have already discussed, and we diagnose ATT-induced hepatitis in the presence of abdominal pain, vomiting, if there is unexplained fatigue, along with yellowness of sclera, and if there is altered sensorium. In case the enzymes are up to 3 times, then with symptoms, or even if just the bilirubin is 2 times of upper limit of normal, then these are indications when we have to stop the hepatotoxic drugs. If there are no clinical symptoms, then the liver enzymes, if they are increased beyond 5 times, then we have to stop the drugs. When we encounter such a patient, we have to exclude viral hepatitis. So we send markers for HBsAg and HCV. In our country, anti-HAV markers may be more useful. And then at the same time, we stop all hepatotoxic drugs. And when children are sick, we may introduce a regimen which comprises of non-hepatotoxic drugs. So, like you had introduced amikacin, levoflox, and ethambutol. These are the drugs which are they do not cause hepatotoxicity. We can introduce the same, and then we repeat LFT after a week and reintroduce the drugs that we have already discussed. At the same time, we should also exclude alternative causes of liver disease.
If the patient is not improving, you don't need to start doing, hepatic surface antigen, hepatitis B, hepatitis C, or ultrasound of abdomen. Only if you repeat the LFT after 3 to 7 days and it's not showing any improvement. That is the time you need to get the viral markers done, and also get the ultrasound abdomen done. Normally, routinely, we do not.
Madam, there is a question in chat box by Dr. Matthew. Please respond to it.
It's very important. अर्जंट बेसिस पे पहिल्यांदा कोणता ऍड करायचं कोणता ऍड करायचं what is the first to introduce and what is the last to introduce?
Yes. I've already replied to this.
Answer
Urvashi ki question.
Okay. Okay.
नहीं ये इसके लिए शक है सेकंड इसका सेकंड चलिए ये So for the reintroduction of antitubercular drugs, we reintroduce only when the ALT and the AST are less than 2 times of upper limit of normal, along with the normal bilirubin levels. We start one drug at a time. This helps to identify the culprit, the drug that is causing hepatotoxicity. Rifampicin may be introduced at 10 mg per kg per dose. After 1 week, we can add isoniazid at 5 mg per kg if the LFT is normal.
Now this algorithm is the adult one. So that is the reason the doses are 10 and 5, because we have picked this up from the standard treatment workflow, because the common was made and there is no separate for pediatrics. But we have to follow the pediatric doses. That is, 12 to 18 milligram of rifampicin and 10 milligram of INH.
Then we add pyrazinamide if the LFT is normal while the patient is on arsen and INH. If ATT hepatitis is severe, that is, if liver failure, coagulopathy, or altered sensorium is present, pyrazinamide reintroduction may be avoided. Another approach may be introducing low dose of one drug followed by full dose after 3 days. Duration of ATT will be counted only when the full ATT has been restarted.
The drug doses, because as I've already said, they are for the adult. Rest, the algorithm remains the same.
So we can reintroduce the ATT if the AST and ALT are less than 2 times upper limit of normal. This can be done either in a sequential way or an incremental way. In the sequential algorithm, we can initiate one drug at a time. We introduce rifampicin. We do the LFT after 1 week, and then we initiate isoniazid in pediatric doses. We repeat the LFT after 1 week, and then we initiate pyrazinamide in pediatric doses. In incremental algorithm, we first initiate with rifampicin and gradually increase the dose by day 4. Once we have achieved the full dose in pediatric doses, we initiate isoniazid in half dose, and then we gradually increase the dose by day to full dose by day 11. And then we initiate pyrazinamide and gradually increase it to full dose, pediatric dose by day 18. So I think that is how this will clarify how we introduce the drugs by monitoring LFT.
88%. If you have an underlying liver disease, and there could be an exceptional circumstance where you are totally unable to start, the RSZ. So there can be 3 scenarios if the child read this. The cirrhosis, हमारे लिए cirrhosis नहीं, और भी कुछ हो सकता है. So just read, because then you have to continue your, modified regimen. Please read it.
So, in case you encounter a child which has an underlying liver disease, so if the child has, according to the child book score, has a score of 1 to 6, he has a stable liver disease. In such a case, you can administer 9 months of therapy with HRE or 2 months of therapy with HRE followed by 7 months of HR. In case of the child having a score of between 7 to 10, that is advanced liver disease, we can introduce one hepatotoxic drug regimen. One of the hepatotoxic drug regimens can be introduced. 2 months of therapy with INH or rifampicin with ethambutol and aminoglycoside, followed by 10 months of therapy with INH or rifampicin and ethambutol. If the child is in the score of 11 to 15, that is very advanced liver disease, no hepatotoxic drug is to be administered, and the child needs to be given 18 to 24 months of treatment using a combination of ethambutol, fluoroquinolone, cycloserine, and aminoglycoside or capreomycin. In case of acute hepatitis, all hepatotoxic drugs are to be avoided. Antitubercular drugs with non-hepatotoxic drugs need to be administered, and we have to wait till there is an improvement in the liver functions if there is no urgent need of ATT. I hope this will clarify the approach that we need to take in case a child presents with drug-induced liver injury while on antitubercular drugs.
And in rarest of rare circumstances, sometimes you may have to give if there is chronic liver disease and you're unable to start the first line drugs, then you go to the reserve drugs, as has been shown, cycloserine. Cycloserine is one of the safest drugs, the reserve drugs, which has got no liver side effect. Even bedaquiline has got, it causes hepatitis. So if the child is on reserve drugs with bedaquiline, then the first drug to be stopped is bedaquiline. In that case, you start with amikacin, levoflox, and cycloserine. So any questions now?
Any more questions from the audience? Or any doubts?
लोग तो समझ सकते हैं.
So to summarize, we had a 13-year-old male child who had presented with fever, cough, breathlessness, and significant weight loss. All attempts were made to isolate the Mycobacterium tuberculosis. However, in spite of all attempts being made, sputum sample being collected, bronchoscopy being done, bowel sample being collected, and even a EVIS TBNA being attempted, the Mycobacterium could not be isolated, and hence a clinical diagnosis of intrathoracic TB was made. Child was started on age appropriate fixed dose combination. However, on this therapy, the child had deranged LFTs, after which a modified regimen had to be introduced. So after this session, we have learned how we approach a child who presents with deranged liver function tests while on ATT, and how we will proceed with introduction of the drugs. If there are any questions from the audience, we would be happy to answer them. And I would also like to mention that the post-test questionnaire has also, the link for the same has been shared in the chat box. You can now also attempt the post-test questionnaire.
Excuse me, ma'am.
Yes, Dr.
Ma'am, sometimes what happens when the hepatic modified regimen is started and we put the patient on amikacin, levoethambutol, and even we have ruled out other causes of hepatitis, still the enzyme goes on deteriorating. So what can be the cause? We have already stopped the hepatotoxic drug, we have put the patient on the modified drug, and all other causes like hepatitis and the viral markers have been sent and they are normal and non-reactive. Still the parameters goes on deteriorating.
Fluoroquinolone. Because fluoroquinolone is also hepatotoxic, although it is not all that hepatotoxic, but in such a case, I would also attempt to stop fluoroquinolone for a while. I mean,
Okay, okay.
So if there are no more questions, we will now come. We are now towards the end of this session. But before we end, I would like to invite Dr. Ashok Bhardwaj, Chairman of the National Task Force, for his closing remarks.
Thank you, Madam Dodika. So first of all, I must thank Dr. Sangeeta for continuing with this pediatric eco clinics. So it is affiliated to her and Dr. Alok and Dr. Dhumika. So I also thank DDG Madam and Dr. Shobani Rajan and the director of NITRD, Dr. Upasana Karwal. And I must compliment the case presentation by Dr. Charu Singh. So I want to thank PGI Chandigarh through Charu Singh to Dr. Matthew for identifying such case and discussion, because may not be the testing for liver function may not be a routine in any institution, but as per the conditions we have to do it. So it was discussed in detail by Madam Sangeeta Sharma, and we must follow it. And then we must follow the guidelines. Whatever the guidelines are given by NTEP, we must follow those. So thank you, everyone. Thank you for joining this Eco Clinic for Pediatric Clinic. So thank you. We'll meet next month on Thursday, the Tuesday, third Tuesday. Thank you.
Thank you, sir. And I must compliment PGI Chandigarh for presenting such a common condition which is very frequently associated with ATT. because the feedback which we have got is that we need to, be presenting more simple cases, the routine difficulties which are encountered. And so the next one request is that find a case which has got ophthalmic, ये बोला?
Optic neuritis.
Optic neuritis. So we will request the next presenting team. Which is the next presenting team? Okay, it is from JJ Hospital, Mumbai. Probably the next presenting team. So we'll request them if they can, enlighten us on the issue of optic neuritis and optic toxicity. I mean, such inputs from your side will give us the right direction. Where we may be missing out. So I'm very thankful to the person who has requested it. Any other question is there in the chat box?
एक क्वेश्चन था ना, ये किसी ने लिखा
About amicus streptomycin or amikacin. So both can be used because streptomycin or amikacin, but preferably amikacin is used these days because it can be given IV. So what we encourage is that you put a IV cannula. So rather than giving intramuscular injections. Otherwise, you can use SC levo or amikacin, levoflox or ethambutol. Any other question?
So if all have attempted the post-test questionnaire, we now discuss the questions.
This is also a change which we are introducing based on the inputs which we have got. That you please discuss the post-test questions.
So our first question was, in a 5-year-old child with typical symptoms and signs of pulmonary tuberculosis, the next logical step is. So in this case, the correct answer is option number A, that is a chest X-ray. Question number 3 was, when drug-induced liver injury is suspected, which of the following is the rational choice? The correct answer was option number C, check levels of hepatic enzymes and bilirubin. Fourth question was, which of the following is not a rational management of drug-induced liver injury? So the correct answer is sequential discontinuation of tuberculosis medications, because here it was asked not a rational management. Question number 5 was, which of the following medications is not associated with drug-induced liver injury? And the correct answer was option number D, that is ethambutol.
And what is that? Do we get the test score? Not yet. So we'll be sharing the test score later.
So with this, we come to the end of this 23rd Pediatric TB Eco Clinic, wherein we had a fruitful discussion and we discussed in depth the management of drug-induced liver injury. We will meet again on 19th of May with a new case discussion where we will learn new things. The presenting team is JJ Medical College, led by Dr. Sushant Mane. So we'll see you all on 19th of May.
Thank you all.
Thank you, sir. Thank you for your support.